the second session is challenges in treatment of cervical cancer. So the first topic is early stage cervical cancer. Is less radical surgery better? It is a debate, and there are two strategies regarding this management. One of them is that less radical surgery will be the best strategy to manage such a case of early cancer cervix. And the second strategy is that it should not be the standard of treatment. So Professor Muheiddine, I know him many years ago. He is very good in debate and to defend his point. So he's going to speak about the strategy that less radical surgery is a safe strategy.
Thank you. So I really have no conflict of interest with this, but cervical cancer is the fourth most common cancer with over 600,000 cases a year. Half of them will die. You have to realize that every 2 minutes a woman dies from cervical cancer. In our part of the world, every 1 hour dies of cervical cancer. More than 99%, if you want, are caused by HPV. But if you look at the world, this is the latest one, you will notice that the majority of these cancers are in the southern part of the world. This is where you really have no vaccination, you have no screening, and more importantly, you have no surgical skill to do the important surgery. And I call them the have and the have not. And where is the vaccination more common? It's in the developed world. Where is vaccination more common? In the developed world. If you add all the cases of cancer in the US, in England, in Australia, there will not be enough number to fit one borough in Mumbai, one borough. We're talking about 11,000 cases in the US. There is nothing, and they vaccinate and they treat. So whatever our discussion here does not really, is not for our country. And I talk later about the 1 dose or 2 dose and how the company is really against the 2 doses and 3 doses because of their money. Anyway, so the treatment of very early cervical cancer, according to the latest NCCN, is surgery. And if after surgery you have certain risk factor, you can give adjuvant treatment, mostly chemo radiation. However, we have a trend in all our oncology toward first less aggressive surgery, okay, whether in breast and vulva and the colon, less invasive surgery, so more minimally invasive surgery, up to a point where we have V-nodes, we have single port laparoscopic or robotic, and more functional, conserving, acceptable, fertility-sparing surgery. So with this in mind, we have the same thing for early cervical cancer. Up to now, the standard of care wherever you go is radical hysterectomy, where you remove the uterus, the cervix, more importantly, the parametria, where the uterus usually inserts, and the upper vagina. This is where most of the early cancer will spread. And when you are about to give clinical trial to demonstrate something against your standard of care, first you do a feasibility trial. Is this thing you are advising feasible? 2, is it safe? And 3, more important, oncologically, is it comparable? And you can either do an equality trial, a superiority trial, or the least of them is a non-inferior trial. وهي يعني أضعف الإيمان بيقولوا بالعربي. I don't know how to translate this. But the non-inferior trial is the most easily done trial because you don't need a large number. I was trying to get to my lecture, and I looked at this very important illustration by John Quincy Adams at the turn of last century, and I asked myself if Ernest Wertheim was among us, what he would say about our discussion, and I opened this at the end of my talk. Okay, now when I looked at attempt at trying simple surgery versus radical, first I look at retrospective trial, and when you look at retrospective trial, the rate of parametrial infiltration, and this is the important thing about the radical, remove the parametria, is less than 1%. And keep in mind this less than 1% when you analyze the trial that looked at, and more importantly, in these very early, low-risk cervical cancer, it is feasible, it is associated with less morbidity, and more importantly, in the majority of the southern world, it does not need surgical expertise. Any gynecologist can do a simple hysterectomy. You don't need to be an advanced surgeon to do this. So it is feasible in the majority of the country that don't have the surgical expertise. Now, the trial that challenged the standard of care, in addition to the retrospective trial, are the one I found are two trials, the CONSERVE trial and the LESSER trial. And in the CONSERVE trial, this was a single-arm prospective trial of conservative surgery. Unfortunately, it's 16 medical centers in 9 countries. So you can imagine the variety of surgical skill and adjuvant treatment that they give. In these 2009 FIGO 1A2 to B1, and eligible are women who had conservative surgery followed by simple hysterectomy, or inadvertent surgery who were found to have a diagnosed cervical cancer. They had 100 women in this trial. The median age was 28, and the stage was mostly 1B1. They had either conization with hysterectomy or inadvertent surgery. The important thing is that the residual disease was only 2.5%, and the median follow-up was around 3 years. The recurrence rate within 2 years, keep this in mind, was only 3.5%. And when you analyze the later data, you have to keep in mind, and when do most of these patients recur? In the first 2 or 3 years. So the conclusion was, yes, if you select your patient correctly, you might do this lesser surgery, conization or conization followed by simple hysterectomy. The other trial was called the LESSER trial, which was a phase 2 non-inferiority trial in only 3 medical centers in Brazil, but it was over 3 years. And it included 1A, 2, and 1B1, simple hysterectomy versus the Kerleux-Monroe type radical hysterectomy type B2. The primary endpoint was disease-free survival at 2 years. Secondary endpoint was overall survival and other outcome. And if you look at the median follow-up of 52 months, they had a small number, 20 versus 20. Very good 3-year disease-free survival, an excellent 5-year disease survival. So these very early cervical cancer have an excellent survival. So whatever you do for them, you should not decrease the survival of 90 and 91%. Longer time, slightly more complication, but not much. And this is potentially non-inferior in this very low-risk early cervical cancer. So the question that Andreas Obermeier asked himself in this editorial for the International Journal, perhaps there is no need for the aggressive surgery. It's less radical, less morbid, better quality of life if it has the same oncological outcome. And that's why the recently presented SHAPE trial in both the ASCO and the IGCS was presented specifically to answer this question. So the trial that was presented by Sarah Ferguson in both of these meetings included 700 women over a 7-year period with low-risk early-stage cervical cancer, 1A2 to 1B1, and either randomized to simple hysterectomy or radical hysterectomy with pelvic lymph node dissection, and they allowed sentinel lymph node biopsy. They were stratified by the co-op group, sentinel lymph node mapping, stage, histological type, and grade. And if you look at the primary endpoint, I don't know why they chose this. They chose the pelvic recurrence rate at 3 years as their primary endpoint, and they call it non-inferior if this unilateral or one-sided upper confidence interval was less, the difference was less than 4% between the two groups. This is the primary intent analysis. It included all patients, and they had a per protocol analysis, which means those patients who started as one treatment but may have changed to another treatment but stays in the same treatment. The secondary endpoint was pelvic recurrence-free survival, extra-pelvic recurrence-free survival, overall survival. More importantly, they had important question about health-related quality of issue, especially sexual function after the surgery. They were well balanced in terms of age, performance status, body mass index, the previous diagnostic procedure. They were mostly stage 1B1. Histology was the same, but I was amazed that a lot of adenocarcinoma, 35% were adenocarcinoma, and grade was the same. If you look at they were more minimally invasive in the simple hysterectomy, which is understood, it's an easier procedure. And if you look at the final pathology, it was only significant for a positive parametria, which was only 1.7%. Of course, only in the radical group, but because this is where you remove your parametria, but it is very, very low. So you're doing 350 surgery for only 6 patients who have parametrial invasion. Think about this. Same adjuvant treatment in both groups. The 3-year pelvic recurrence rate difference was only 0.35% between the two groups, and all the other parameters, the 3-year recurrence-free, extra pelvic recurrence-free, 3-year recurrence-free, and 3-year overall survival was very high, 99% point something. And this is very important. These are a group of patients who have a very high overall survival rate, okay? So you really should not expose them to unnecessary surgery with such a high survival rate. So in the intent to treat analysis, the difference was 0.35%, which was less than non-intended non-inferiority. Hence the conclusion, it's really non-inferior. But in the per protocol analysis, the difference was 0.42. But this was not the primary endpoint. The primary endpoint was the intent to treat analysis. It showed non-inferior. There were 5 cervical deaths, a bit more on the simple hysterectomy group, but only 1.1% and no difference between the two. In terms of the operative complication, there were, of course, more bladder and ureter complication, but non-significance in the radical group. If you look at the less than 28 days post-op adverse event, of course, there were more urinary incontinence, more urinary retention in the radical hysterectomy group, but more pain in the simple hysterectomy group. On the long-term follow-up, again, the same, more urinary incontinence, more urinary retention in the radical group. And as far as health-related quality of life, including sexual, they were much better in the simple hysterectomy group. So the conclusion of the author, not mine, is that it is non-inferior if you look at the 3-year disease pelvic recurrence rate between the two groups, with less urologic, better quality of life, and better sexual health. And they said it should be the new standard of care, which a lot of us were asking for since a long time. Now, if you analyze this, of course, the primary intention group was demonstrated, the 0.35%. The extra pelvic recurrence were very low. The complication rate were better, and the health-related quality of life was good. So can it be considered as the new standard of care? I'm supposed to say yes. My point is that the positive of the trial, it's the only randomized trial. It's non-inferior. Large number of patients, group well-balanced except for the MIS. Very few more than 2 centimeters. Very few parametrial invasion. They looked at the health-related quality of life. He gave me 5 minutes, Walid. Walid gave me 5 minutes. Yalla. Overall survival is in the line of current overall survival, more than 90% for the 5-year survival. And if you look at the negative, it's international study. There were too many centers, difficult to standardize the surgery. The percent of minimally invasive is not well balanced. And the primary endpoint, I don't know why they chose it, the pelvic recurrence rate at 3 years. I'm not sure why they did that from study. So should be more careful in adapting new standard of care after a single randomized trial. Can we learn from history? Well, if you look at the WHI, as gynecologists, we're all familiar. Look what happens at hormonal therapy after the worst trial in the history of hormonal therapy. Women stop using till now hormonal therapy because of the single randomized trial in hormonal therapy, which is widely done. I'm not going to argue about the minimally invasive. I think the next debate will argue. But if you look back, a lot of people look back. You know, maybe in 2 centimeters, it's better than more than 2 centimeters. If you look at robotic surgery versus laparoscopic surgery, when you look back, you find, oh, maybe the difference is because they included a lot of robotic. If they stuck with laparoscopic, maybe it is better. If you look at the so-called trial now, they are in debate. Maybe we should have not used a manipulator. Maybe we should not use CO2. Maybe we should do a cone. Maybe we should do an intracorporeal colpotomy, like the new gorilla study that was presented in the IGCS. Anyway, I leave it up to you to think, what would Ernest Wersheim say if he was here about the new standard of care? And if you're going to ask me about this illustration, I asked my psychology daughter to interpret this illustration for me. What does it mean? I can explain to you in the answer and question. Thank you. Thank you very much.
Thank you.